Welcome to this session on economic evaluation models in health technology assessment, a critical foundation for anyone involved in healthcare decision-making, medical affairs, or market access. In today's world, health systems face constant pressure to deliver better outcomes while managing limited budgets. This is where economic evaluation models become so powerful. They help us answer questions like, can we afford this new innovation? Is it worth the cost? Which option delivers the most health benefit for the resources we invest? In this tutorial, we will explore the 4 core models used globally to guide evidence-based decisions: budget impact analysis, to forecast the financial impact of adopting a new technology; cost-benefit analysis, to weigh costs and benefits in monetary terms; cost-utility analysis, to measure value using quality-adjusted life years; cost-minimization analysis, to find the most efficient option when outcomes are equal. Together, these models form the backbone of health technology assessment, helping ensure that new treatments and programs are not only clinically effective, but also affordable, sustainable, and equitable. Let's first explain the budget impact analysis, one of the most practical tools in health technology assessment. Budget impact analysis answers a simple but critical question. If we introduce this new technology, how will it affect the healthcare budget over a specific time frame? Unlike cost-effectiveness analysis, which asks if something is worth the money, budget impact analysis asks whether the health system can actually afford it and what financial trade-offs might be needed. Here's how it works. Budget impact analysis calculates the total cost of adopting a new intervention compared to current practice. It looks at the number of eligible patients, drug prices or procedure costs, administration expenses, monitoring costs, and sometimes even savings from avoided hospitalizations or complications. The goal is to project the budgetary consequences over a period, usually 3 to 5 years, so payers can plan ahead. Let's look at a couple of examples. The first example is about a new diabetes medication. Let's say that the health system currently treats 10,000 patients with older, cheaper diabetes drugs. A new medication enters the market that's more expensive per dose, but reduces hospital admissions due to better blood sugar control. Budget impact analysis will model how many patients are expected to switch, what the increase in drug spending will be, and how much could be saved from fewer hospitalizations. The result might show a modest net budget increase in the first year, but cost savings after year 2, making it easier for payers to justify adoption. Let us see another example about a new vaccination program. Suppose a new vaccine is introduced to prevent a seasonal illness. Budget impact analysis would estimate the cost of vaccinating the target population, including distribution and administration, and compare that to the savings from avoiding doctor visits, treatments, and work absences. The analysis could reveal that while the upfront investment is significant, the health system saves millions in avoided treatment costs during the same year. These examples show why budget impact analysis is so important. It gives decision makers a clear picture of short and medium-term affordability, helping them plan budgets, negotiate with manufacturers, and avoid surprises once a technology is adopted. Budget impact analysis is not about proving value. That's where cost effectiveness comes in, but about ensuring that an innovation can be integrated into the health system without destabilizing resources. Now let's explore cost-benefit analysis, one of the key tools used in health technology assessment to compare healthcare interventions. Cost-benefit analysis answers this question. Are the benefits of this intervention worth the money we are spending? And how do they compare to other possible uses of those same funds? What makes cost-benefit analysis unique is that it expresses both costs and benefits in monetary terms, allowing us to compare completely different types of interventions using the same unit, money. Here's how it works. First, we calculate the total cost of the intervention, including drug costs, administration, hospital stays, and follow-up care. Then we estimate the monetary value of the outcomes: fewer hospitalizations, improved productivity, avoided complications, or lives saved. The difference between the two gives us the net benefit. Let's see two examples to make this clear. Example 1. Workplace flu vaccination program. A company considers funding flu vaccinations for its employees. The total cost is $50,000 for vaccine doses, staff time, and logistics. The benefit is fewer sick days and higher productivity, valued at $120,000 in avoided lost work hours and medical visits. The net benefit is $70,000, making it a positive investment and easy to justify. Another example, this time about road safety intervention. A health department evaluates installing new road barriers to prevent accidents. The project costs $1 million. If this intervention is expected to prevent accidents leading to $3 million in hospital costs, emergency response, and lost productivity, the net benefit is $2 million, showing a clear economic case for implementation. These examples show how cost-benefit analysis helps decision makers prioritize funding across very different programs by comparing them on the same financial scale. It is especially useful when policymakers must decide whether to invest in a new drug, a public health campaign, or infrastructure, and need to choose the option that delivers the highest return on investment for society. Now let's move to take a closer look at cost-utility analysis, one of the most widely used tools in health technology assessment. Cost-utility analysis goes beyond looking at costs and outcomes. It tells us how much we are paying for each unit of health benefit, measured not just in years of life, but in the quality of those years. The most common measure used is the quality-adjusted life year, which combines length of life and quality of life into a single number. Here's how it works. First, we calculate the total cost of the new intervention and compare it with the current standard of care. Then we measure the gain in quality-adjusted life years. Finally, we divide the cost difference by the gain in quality-adjusted life years to get a cost per quality-adjusted life year. This is then compared with the willingness to pay threshold to decide if the intervention is considered cost-effective. Let's make this concrete with two examples. Suppose a new treatment costs $50,000 more than the current therapy, but gives patients an additional 1.5 quality-adjusted life years. The cost per quality-adjusted life year would be about $33,000. If the country's willingness to pay threshold is $50,000 per quality-adjusted life year, this treatment would be considered cost-effective and likely recommended for reimbursement. Another example, hip replacement surgery. Imagine a study comparing hip replacement surgery to non-surgical management for severe arthritis. The surgery may cost $10,000 more upfront, but patients gain significant improvements in mobility and quality of life, adding the equivalent of 2 extra quality-adjusted life years. This would result in a cost of $5,000 per quality-adjusted life year, a very cost-effective result in most healthcare systems. These examples show why cost-utility analysis is so powerful. It allows decision makers to compare very different interventions, from drugs to surgeries to public health programs, using the same common yardstick, helping ensure that limited healthcare resources are spent where they deliver the biggest impact on both the length and quality of life. Finally, let's talk about cost minimization analysis, the simplest of all economic evaluation models, but also one that only applies in very specific situations. Cost minimization analysis is used when 2 or more interventions produce exactly the same outcomes, meaning they have equivalent effectiveness and safety profiles. Since the outcomes are the same, there's no need to measure quality-adjusted life years or other benefits. the decision becomes purely about choosing the option with the lowest total cost. Here's how it works. First, we confirm through strong clinical evidence, often head-to-head trials or meta-analyses, that the outcomes are truly equivalent. Then we calculate all the direct and indirect costs for each option, including drug acquisition, administration, monitoring, and adverse event management. The least costly option is considered the most efficient choice. Let's see two examples. Let's see an example about a branded drug versus a generic. Suppose a branded blood pressure medication and its generic version have identical efficacy, safety, and patient adherence rates. Cost minimization analysis would simply compare their total costs. If the generic version is significantly cheaper, it would be the preferred option for formulary inclusion. Another example about two equally effective surgical techniques. Imagine two surgical approaches for the same procedure, both with the same success rates and complication rates. One approach can be done as a day surgery with lower hospitalization costs, while the other requires an overnight stay. Cost minimization analysis would favor the day surgery technique because it achieves the same health outcomes at a lower overall cost to the health system. These examples highlight why cost minimization analysis is such a practical tool when outcomes are proven equal. It helps healthcare systems save money without compromising patient care, freeing up resources for other innovations that deliver additional health benefits. Let's elaborate more on these examples because it shows how important it is to understand not just the numbers, but also the strategy behind market access discussions. When a healthcare decision maker perceives that the efficacy and safety of a new medication or vaccine are equivalent to an existing option, they will almost always adopt a cost minimization analysis model. This means they will simply choose the least expensive option, which, in practice, could prevent your innovation from ever reaching patients, unless there is a clear and measurable clinical or safety advantage. This is where cross-functional collaboration within a pharmaceutical company becomes critical. It's not just about the access team working alone, it's a coordinated effort. Medical affairs colleagues play a key role by generating and communicating real-world data, patient-reported outcomes, and evidence that highlights benefits beyond clinical equivalence, such as improved adherence, reduced side effects, or better long-term disease control. Health economics and outcomes research, HEOR, teams build robust cost-utility analysis models, showing how the innovation delivers more quality-adjusted life years for the investment and linking those outcomes to improved population health and resource savings. Market access professionals then translate these insights into value dossiers, payer presentations, and budget impact models that resonate with decision makers. Commercial and pricing teams work to ensure the product's price and contracting strategy align with its demonstrated value, so that the conversation focuses on outcomes and not just cost. Medical and policy advocacy teams engage with external stakeholders, from patient advocacy groups to government agencies, to ensure that broader societal benefits, like productivity gains and equity considerations, are part of the discussion. Together, this cross-functional approach shifts the conversation away from simple cost comparisons toward a cost-utility analysis perspective. This reframes the decision in terms of value creation, not just cost, allowing decision makers to see the hidden benefits, including improved quality of life, reduced complications, and long-term savings for the healthcare system. By aligning on this strategy internally, pharmaceutical teams can help ensure that innovative therapies reach the patients who need them most, even in highly cost-sensitive environments. As we wrap up this session, let's step back and see how these models work together to guide smarter healthcare decisions. Budget impact analysis helps us plan for affordability. Cost-benefit analysis compares investments in health against their economic returns. Cost-utility analysis allows us to look at both the quantity and quality of life gained for each dollar spent. And cost-minimization analysis ensures we choose the most efficient option when outcomes are the same. When used together, these models give decision makers a 360-degree view of value: clinical, economic, and societal. They make funding decisions more transparent, defendable, and patient-centered. The next time you read a health policy recommendation, a reimbursement report, or a formulary decision, think about how these tools were applied in the background. And as you continue your journey in medical affairs or market access, remember, mastering these models is not just about crunching numbers. It's about ensuring that every decision we make drives the maximum benefit for patients while keeping healthcare systems sustainable for the future. Thank you for joining me, and I encourage you to keep exploring the world of health technology assessment economics, because better decisions start with better evidence.